Good afternoon. My name is Andrew Luhrs, coming from Brown University. I'll be presenting our data on body mass index as a predictor of surgical site infection after a laparoscopic appendectomy. I have no disclosures. Surgical site infections are an increasingly common and significant source of morbidity. Surgical site infections are associated with wound complications such as dehiscence, incisional hernia, increased length of stay, and up to a threefold increase in mortality, increased risk of ICU admission or readmission, and increased costs. The incidence of surgical site infection in a patient's undergoing surgery are estimated between 2 and 5%. In fact, surgical site infections are the most common cause of nosocomial infections, accounting for about 20% of hospital-acquired infections. Nearly 60% of surgical site infections are estimated to be preventable. Therefore, the rates of surgical site infections are being increasingly linked to pay-for-performance metrics and payment incentives. Obesity has been identified as a significant risk factor for developing surgical site infection in a diverse body of literature. And odds ratios have been reported somewhere between 1.5 and 8 for obesity as the risk for developing surgical site infection. While obesity is certainly a surrogate for other factors known to cause surgical site infections, such as diabetes or longer operative times, it seems to be also an intrinsic risk factor for the development of a surgical site infection. A number of authors have shown that minimally invasive techniques lead to decreased risk of surgical site infection in the obese patient. In fact, this has been well documented in the bariatric literature. While data shows that the obese patient has a decreased risk of developing a surgical site infection after laparoscopy as compared to laparotomy, there's limited data as to whether the obese patient as compared to the non-obese patient is at increased risk of surgical site infection after laparoscopic surgery in non-bariatric GI surgeries. This study's aim was to evaluate the effect of obesity on surgical site infection after laparoscopic appendectomy, as this is a commonly performed laparoscopic procedure. We hypothesized that the obese patient will have a higher incidence of surgical site infection after laparoscopic appendectomy and question whether there is a BMI threshold above which perioperative protocols should be adjusted to reduce the incidence of surgical site infection. This is a retrospective review of the ACS NISQIP database. The ACS NISQIP database was retrospectively queried for all adult patients 18 years or older who underwent laparoscopic appendectomy between January of 2005 and December of 2013. Patients were excluded if their height and weights were not recorded, if greater than 50% of their co-variable data was missing, or they were pregnant at the time of surgery. They were also excluded if their laparoscopic appendectomy was converted to open. Primary outcome measured was surgical site infection within 30 days, which was defined as purulent drainage from the incision, isolated organisms from the incision, peri-incisional swelling, erythema, and warmth, or a documented organ space infection on imaging. Secondary outcomes analyzed were 30-day mortality, hospital length of stay, and morbidity, including wound dehiscence, UTI, pneumonia, acute renal failure, and documented sepsis. Just under 78,000 patients were identified using the mentioned criteria. Of those patients, 2,187 patients, or about 2.8%, developed a surgical site infection in the post-op or perioperative period. Of those patients, approximately 50% developed a superficial surgical site infection, while the remainder developed an organ space infection. As shown here, when comparing patients who developed a surgical site infection to those who did not, the patients who developed a surgical site infection were more likely to be male, diabetic, an active smoker, malnourished or hypoalbuminemic, and have an ASA class of 3 or greater. Also, patients in the surgical site infection group were significantly older and had significantly higher BMI. Intraoperatively, patients in the surgical site infection group were significantly more likely to require an intraoperative transfusion or have perforation or abscess noted on surgical evaluation or longer operative times over 120 minutes. When evaluating outcomes, There was no association noted with mortality between the two groups. However, patients who developed a surgical site infection were more likely to have wound dehiscence, pneumonia, UTI, or documented sepsis. Interestingly, patients who developed a surgical site infection had a 12-fold higher risk of developing any other complication. Patients in the surgical site infection group had significantly increased length of stay and higher rates of readmission. On a multiple logistic regression analysis, the following factors were identified as increasing the odds of developing a surgical site infection. Notably, BMI greater than 30, perforation or abscess on surgical evaluation, ASA greater than 3, male gender, or actively smoking patients, malnourished patients, and longer operative times. Surgical site infection after laparoscopic appendectomy has an overall rather low incidence rate. As our data shows, it occurs in about 2.8% of patients, which is consistent with other published data. While overall the incidence is low, those patients who do develop a surgical site infection have a 12-fold increased risk for developing another complication and have an increased length of stay and increased readmission rates. What's clear from this data is that obesity is a significant risk factor for development of a surgical site infection after laparoscopic appendectomy, conferring as much risk as other well-documented risk factors such as malnutrition and active smoking status. Patients with a BMI of 30 or greater undergoing laparoscopic appendectomy were more likely to develop a surgical site infection. While it's true that many organ space infections are likely the result of the presenting disease process, approximately 50% of these patients developed a superficial surgical site infection, which represents a potentially preventable complication. What's less clear from our data is how to mitigate this risk. Perioperative care bundles have been developed by the colorectal literature and have seen a 3 to 4-fold improvement in rates of surgical site infection. In fact, a colorectal care bundle has recently been implemented in the last several years. At our institution, we've noted similar improvements in rates of surgical site infection. In relation to the obese patient undergoing laparoscopic surgery, perioperative protocols should be adjusted in these patients to reduce the incidence of surgical site infection. Most bariatric centers of excellence have perioperative management strategies to mitigate the risk of complications after bariatric surgery. However, it's our observation that these practices are rarely transferred to the obese patient undergoing elective or emergent general surgery. There are limitations to this study as we looked only at laparoscopic appendectomy. Although I expect they are, it's not clear based on our data that our findings are generalizable to other procedures. Additional study is needed to identify interventions which would effectively reduce the risk of surgical site infection in this population. And moving forward, we plan to develop and implement a perioperative care bundle for the obese surgical patient and study its effects prospectively. Thank you.